founded several nonprofit organizations, such as the Center for Viral Hepatitis and Asian American Stomach Cancer Task Force, and has published articles on ethnic health disparities and is currently the chair of the New York Health Forum. Dr. Hyun.
Hello, everyone. It's great to be here. My name is Chul Hyun. Thank you very much for inviting me to speak. This is really great to see you all here this evening. I'm a gastroenterologist, and I practice, GI and hepatology in New York and New Jersey area. It's really great to be here and a part of this conference. First of all, I want to congratulate Aki and all the members of Hope Stomach Cancer for doing an amazing job in empowering and advocating for the gastric cancer patients. I think your work is crucial because it gives patients not only the ownership, but also the power to navigate the many difficult problems that there may be in the future. As a physician, I think empowering patients is actually one of our duties. The way that I try to empower my patient is trying to actively listening to their problems and their questions. I've been in practice over almost 30 years, but I must admit that I still on and off fail to listen to my patients. And I do see a lot of patients who come to me and complain that that their doctors don't listen to their patients. And in fact, today's electronic medical record system doesn't really help the matter because the patients will come and say, "Listen, in 15 minutes of sitting in the office, the guy has just looked at me maybe 1 or 2 minutes, and he or she was busy, watching the monitor. I mean, they're working on the computer monitor. So it's very difficult, and it's not as easy as it sounds. What I mean by listening is kind of like active listening, which is really goes beyond just hearing the words, but trying to understand the meanings and uh, the feelings behind all those words, and also I have to understand the context as well. With all this, what a patient's trying to say with their words and also their gestures. So this is a very challenging, very difficult job. But if there is active listening, it's the job is a half done because it not only establishes a certain empathy and rapport or some sort of like a faith with patients, but it can also help the patients to, you know, the power to allow them to navigate their healthcare issues. So I think this is a win-win situation actually for both patients and the physicians. Um, I think we all have to remember that all the clinical decision making is on behalf of the patients, not the healthcare providers. On a personal note, it's really great to be here in Arlington because I used to live here in this area, not too far actually from here, maybe about a half mile from here. And many years ago, I did my residency in Georgetown and internal medicine. Just ran into an old friend of mine, John Marshall. I think John was the first year, I guess, when I was a senior resident. So, but I haven't seen him for many years. So this is was a very nice reunion actually, and it's so being here in Arlington actually brings back many old memories, and one of which I'd like to share. It was back in 1986. I was doing my internship, and it must have been about 2 weeks before Christmas. I got a call from my parents who were living in Miami, Florida back then. And so my mom was saying that, hey, your dad has passed some black melanic stool, which is heme positive, and he's been complaining of some epigastric discomfort, which has been progressing and recently. And so obviously, he flew to DC next day and underwent gastroscopy. And I still vividly remember seeing a small ulcer sitting in the antrum of stomach, which had a stigmata of recent bleed. It wasn't bleeding anymore, but it was like a small ulcer. The biopsy, which came back next day, signet ring cell adenocarcinoma. So he did have a stomach cancer. Um, well, he was lucky because his presentation was a very noticeable black stool, and nobody can really, dismiss that. And it was something that was very striking, and then he began to relate to his symptom in epigastrium, because most of the time, many of you, I'm sure, we all do have on and off epigastric discomfort, right? And we will dismiss it as a reflux disease, and you go see your doctors, and they will probably treat you with PPIs. Back then, actually, the H2 antagonist, and we still use them actually. But so he was lucky, because I don't think he would have called me unless he had a black stool. So he had a very lucky presentation, and turned out to be an early cancer. I think the stomach cancer uh, in the U.S. is a serious healthy issue. Uh, if we combine all the stages, you probably know about this. The survival rate for stomach cancer in this country is dismally low at 33%, as compared to 72% in Korea, by the way, and 65% in Japan. So we're really behind, all right, with respect to gastric cancer. And I think in this aspect, we are really more like a third world developing country. That's where we are. The instance of stomach cancer varies between different ethnicities. You all know that. And recent studies have demonstrated that for people above age 50, the instance of stomach cancer can be 3 to 14 times higher in certain ethnic populations, such as Asian and Latin American populations, as compared to non-Hispanic whites. So, in addition to the the disparities in incidence and the mortality rates of stomach cancer, there is a serious and market a funding disparity in stomach cancer. So if you look at the funding situations from, for example, NCI, and looking at the past 15-year records, we find that the uh, which cancer do you think got the most funding? Breast cancer, right? You're right. Breast cancer got 550 million the annual funding, an average, whereas the stomach cancer got 13 million dollars. So, well, I mean, you really can't compare. They're not really apple to apple, right? So, the breast cancer is 10 times more common than gastric cancer in this country. So if we look at the disparities of the funding, we have to analyze it using one of the tools that we use to analyze the disparity is what we call the funding to lethality score. That is the ratio of a funding, how much money is being funded for specific for specific cancer, over the lethality, whereas the lethality is defined as mortality incidence ratio uh, multiplied by a person's years of life lost. So, if you compare the funding to lethality score of breast cancer, it comes out to be like 180. Whereas if you look at the gastric cancer FDL score, it's 1.8. There's a hundredfold difference in the funding between these two cancers. Not only that, if you look at the funding, there's a pattern here that cancers that are more prevalent among non-Hispanic whites are get funded more, such as not only breast cancer, but leukemia and lymphoma, whereas the cancers that are less prevalent in non-Hispanic whites and more prevalent in the minority populations, such cancers such as uterine cancer, stomach cancer, liver cancers, the funding is very low. So these, the NCI funding disparities, I mean, there has to be addressed, and there has to be something that needs to be done about this. So these are the reasons actually why we created the stomach cancer task force. Our headquarters is based in New Jersey, and we have a great network of physicians in the community. We basically have a mission to bring together the community and the physicians and the policymakers to find a innovative approach to have this to spread this increase this awareness about the stomach cancer and this disparities. And we have two specific goals. One is to not only to increase the awareness about the stomach cancer in disparities, but we also want to be able to develop a screening guideline for the population at high risk. So these are our missions. Tomorrow at 12 o'clock, we have a forum. We have a flyer out there on the desk outside. Please don't forget to pick one. And we do have about 2 hour lasting forum. It's going to be during the lunch time from 12 to 2. I know you will be busy moving around from office to office, but it's a lunchtime anyway. So please stop by and grab a bite and listen to our speakers. Actually, John's going to speak in our forum again, but we'll have several other speakers. Your own Mahathi and Aki are going to speak as well. So I would love to see you in our forum tomorrow. And if there are any questions, I'll be happy to address and answer any questions. Yeah.
So the developing screening guidelines, so to speak, you want to speak with the Congress people tomorrow? Is that one of the goals?
Yes, yeah. Eventually, I think the ideal thing would be to have Congress create a caucus on stomach cancer, through which they can, eventually develop a screening guideline, at least for the high risk populations. The studies are out there, by the way, that have shown the cost effectiveness of gastric cancer screening by endoscopy, gastroscopy, in high risk populations. Uh, there are plenty of data out there, and the data is very strong, and it's about time the government has to do something about it. One more question. I know we have a few more minutes. Yes.
So are you saying, okay, for example, with colon cancer, people tend to get colonoscopies, what, at age 50 and
45, yeah.
or 45? Oh, sorry. That's okay. Thank you. So would having some sort of encouragement for people to get endoscopies at a certain age, would that be the way to catch the stomach cancer?
Yes, exactly,
routinely?
exactly. If you look at the studies from, for example, from Japan and Korea, there's several studies in Japan where they have looked at the people 50 to 75 and biannual gastric cancer screening with either upper GI or gastroscopy. It was very cost effective. There's a big study from Korea from age 40 on. If you look at them, it is a biannual gastric cancer screening by gastroscopy was very cost effective. It saved a lot of lives. In fact, 25 years ago, the survival rate of gastric cancer in Korea was about 35%. And 20 years, it increased to 70%.
Is that what they're doing? Is that what's making the difference in Korea and
We
Japan?
think so. We think so. We think this is what's making difference in Korea.
That's incredible.
Yep, it is incredible. Yeah. And
you.
yep. Any questions? Yeah, okay, sure, please.
So you said tomorrow the gastric cancer task force luncheon is from 12 to 2.
12 to 2, yeah.
Okay, because in our program it's 11
Right.
to 1.
Right,
So-
we're joining for the program and the lunch, correct?
Yeah,
And then-
we're providing lunch, and so we want you to come stop by and have lunch and attend our forum. We will have a few congressmen come speak, and we'll have Dr. Marshall speaking, and we'll have another gastroenterologist from town, actually, Dr. Hong, who will speak on the screening and diagnosis of gastric cancer. We will have Aki and Mahati speak also, and we'll have a good Q&A session afterwards.
But if you have 2 p.m. meetings or so, obviously the meetings will then come and you'll have to leave early. Yes.
So we'll look forward to meeting you tomorrow again. Okay. Thank you very much.